Good morning, everyone. For those who I haven't met yet, my name is Moshe. I'm one of the EM3s, and today we'll be talking about morning sickness, Hyperemesis gravidarum, and its toxic mimics. So the agenda for today, we'll quickly define Hyperemesis gravidarum and its diagnostic criteria. We'll go through the appropriate ED management, including prompt recognition, initial stabilization, appropriate workup, and then the algorithmic decision making with regard to treatment. We'll recognize the serious complications that may arise from disorders of nausea and vomiting in pregnancy. We'll outline the evidence-based treatments for HG relevant to the emergency medicine physician. We'll briefly review how differences in pregnancy physiology influence drug metabolism. And then finally, we'll explore some toxic and metabolic mimics of nausea and vomiting in pregnancy. So, as an overview, nausea and vomiting in pregnancy is really a spectrum of disease. It can range from self-limiting, minimal to mild symptoms of nausea and vomiting, all the way to severe disease courses, long-term sequelae. Many experience the quote-unquote typical morning sickness pattern, while many others will have episodic or even persistent symptoms. Up to 70% of pregnant individuals will experience some degree of nausea and vomiting in pregnancy, but as opposed to physiologic NVP, pathologic hyperemesis gravidarum is severe, intractable nausea and vomiting, typically within the first 16 weeks of pregnancy, and has a prevalence of about 0.3 to 3% of all pregnancies. Like many other complex disease processes, the pathophysiology is thought to be multifactorial, but is still pretty poorly understood. There's definitely an element of genetic predisposition. There's a lot of signaling pathways and receptors that are involved, specifically with regard to the disequilibrium of pregnancy-related hormones. Increased levels of estrogen and GDF15 or growth differentiation factor 15 like directly bind to area postrema in like the central part of the medulla, which can directly induce vomiting. There's also the established thought that increased levels of beta HCG, the primary pregnancy hormone, since it shares a alpha subunit of the TSH molecule, and that there's some cross-reactivity between the two, that there's this element of gestational transient thyrotoxicosis. In one prospective cohort study, they found that almost 10% of people in pregnancy will have some element of gestational transient thyrotoxicosis. And anecdotally, we see it's higher in incidences of multiple gestations with elevated betas, as well as molar pregnancies with molar betas, further giving more anecdotal evidence that there's some cross-reactivity and that this is at least one of the proposed mechanisms through which HG manifests itself. There are additional factors, placental size. There's also a strong theory about serotonin signaling. So not fully understood, but we have a pretty good basis in terms of what may be involved. And as we do every day in like all throughout our day, we have to discern about which patients to test and which patients to treat. In our case, it's really more screening when we talk about testing. There are multiple validated scoring tools. One's called the Pregnancy Unique Quantification of Emesis, or PUC, and the other is called Hyperemesis Level Prediction, HELP tools, which can help quantify severity of disease. We're not going to go through all the nitty-gritty details, but do know that these tools exist, the PUC score as well as the HELP score. They're calculators, they're accessible, you can look them up and screen your patients appropriately, but we're not going to go through the details at this point. A little beyond the scope for today. So, our diagnostic criteria. Traditionally, when you read through most of the OBGYN literature, the gold standard, so to speak, in terms of diagnosing HG as the most severe form of nausea and vomiting in pregnancy was the Fairweather criteria. It was first reported in 1968. There are six absolute like criteria that all need to be met in order to make disease diagnosis. Those are more than 3 episodes of nausea and vomiting per day, significant weight loss, more than 5% of the pre-pregnancy body weight, ketonemia, electrolyte imbalance, volume depletion, and with a typical onset of 4 to 8 weeks gestational age. More recently, this has been seen to be somewhat outdated. It was very strict. It wasn't really generalizable to a lot of people who were suffering from nausea and vomiting in pregnancy. So in 2021, there was a mixed methods, multi-stakeholder international consensus definition. They literally gathered a bunch of different specialists in the field and came up with a new working definition. And it's called the Windsor criteria. And it's a little more flexible, it's a little more generalizable, and better encompasses like screening your patients appropriately. And this one includes nausea and vomiting, at least one of which is severe, the inability to eat or drink normally, strongly affecting activities of daily living, beginning in early pregnancy, which they define as less than 16 weeks gestational age. Those are your mandatory criteria. And then an optional, what they call contributory criteria, is signs of dehydration, but it's not mandatory. All right, so we've appropriately screened our patients. How are we going to evaluate them? Your history should really be focused on targeting questions surrounding anorexia, weight loss, quantifying that if possible, and just inability to really tolerate orally. On your initial assessments, pay close attention to their vital signs. These are patients whose, heart rate, you should just look at their heart rate. This is someone who it may be a good idea to take the extra time to do orthostatic blood pressures, and even pay close attention to their respiratory rate. We'll get more into the metabolic, like acid-base status, but paying close attention to their breathing may be another clinical clue you can use. On their physical exam, look at their mental status. Are they lethargic? Are they sleepy? Look at signs for volume status. So look at their mucous membranes. Are they dry? On their cardiac exam, do they have appropriate cap refill? Are their extremities warm and perfused? Do they have really profound volume depletion and their skin turgors increased? On abdominal and GU exam, appreciating the uterus, being able to estimate gestational age, and then if there's any focal tenderness versus more generalized abdominal tenderness. Your workup should always start with an EKG. It's a very quick, easy way to screen for severe electrolyte derangements, identify any early signs of that may predispose them to malignant arrhythmias. Lab work should include beta HCG, VBG, in case they have an elevated anion gap. It would be helpful to know what component of that may be due to an elevated lactate. CBC to look for anemia, your BMP to look for your electrolyte derangements and kidney function, LFTs, TFTs, your amylase lipase, beta hydroxy, and then a urine test to look for some of the ketones. Imaging will kind of be stepwise, but for those, especially without a confirmed IUP, that's a great place to start. And it's an easy way to rule out kind of a multi-gestational or molar pregnancy situation. Differential diagnosis, keep it really broad. We'll talk more later about the toxicologic and like metabolic considerations. But for your primary GI pathology, colic, pancreatitis, delayed gastric emptying, your cystitis from kind of mass effect, your ureterolithiasis and pylos, and of course, like rule out your emergent surgical pathology like obstruction or perforation. All right, so we've identified our patients, we've worked them up. What are, the consequences or complications we should appreciate that may result both to the pregnant individual as well as our second patient, which is our fetus. Broadly, we can like categorize it into maternal and fetal risks. Maternal risks can include, in severe cases, like Wernicke's encephalopathy. We actually had a case not too far back where there was a case of a Valsalva retinopathy, where a pregnant woman who like just had such bad vomiting, actually had like because of all the Valsalva pressure, actually had a pre-retinal hemorrhage from such severe nausea and vomiting in pregnancy. Up to 50% will have some like laboratory diagnosis of an electrolyte imbalance that needs repletion. GI, there can be Mallory-Weiss tears or esophageal ruptures. And although rare, there are like, and there's paucity in the literature, but they estimated anywhere around 20% of like severe cases will have like long-term psychological or psychiatric complications. And then also not very well reported in the literature, but generally accepted as less than 2% for like Wernicke's arrhythmia or seizure. Can a PGY1 in the room tell me what is the malignant arrhythmia we see in this EKG? Might not be able to see your results, but I'm assuming someone's typing in torsades. Great. And now someone else. Which electrolyte arrangement can we see in this EKG? And how does it predispose us to this malignant arrhythmia? So I'm hoping someone said hypokalemia. You can look for generalized ST depression with our flattened or inverted T waves and the formation of U waves. And as a consequence of that, you get prolonged QTC. And with the prolonged QTC, you can get your RNT phenomenon, which predisposes you to torsades. One just clinical pearl here in the setting of severe hypokalemia, already at the point where you're seeing like EKG changes, they're almost certainly hypomagnesiemic as well. And with regard to your repletion strategy, you should always replete mag before or concurrently with your potassium, because inappropriate stores of magnesium will actually just cause further wasting of potassium. You need magnesium to inhibit the ROMK channels in the kidneys to allow for adequate reabsorption of potassium. If you don't replete it at the same time or before, they're just gonna kind of pee out what you give them. All right, so we've talked about the potential consequences of what can happen if we don't appropriately treat our patients. So let's talk about management strategies. In 2018, ACOG actually put out a practice bulletin outlining a recommended algorithmic approach to treat nausea and vomiting in pregnancy. We're not going to go through like read all the details, but just kind of a generalized stepwise approach. Always start with your easiest, cheapest, basic, least harmful strategies. So in this case, our non-pharmacologic strategies. They say to stop prenatals. A lot of times the iron component can be very GI upsetting, and to only take folic acid. They recommend using ginger or acupressure as like additional strategies. And although not on this list, in consultation with our toxicological attendings, they also recommended aromatherapy, such as like alcohol swabs, right? Smelling alcohol swabs as an additional strategy that can help many patients. If that fails and you have to escalate therapy, our first line pharmacologic intervention is oral pyridoxine with doxylamine. There are various regimens in terms of dosing and times a day, but all of them have some combination of B6 and doxylamine. If you further need to escalate therapy, there's oral first generation histamine antagonists and our phenothiazines. So those include your dimenahydramate, diphenhydramine, chlorperazine, or promethazine. At this point, if they're this refractory to treatment, the algorithm says, assess for dehydration and give IV fluids, typically with dextrose if there's evidence of ketonemia on your laboratory assessment. And at this point, if they're still like refractory to treatment, you have to escalate to IV therapy. So at this point, you're going to continue with your phenothiazines in like IV formulations, and you can add on your serotonin antagonists like ondansetron, as well as metoclopramide, dopamine antagonists, and prometillant. And then your final kind of management strategy will be with your phenothiazine and D2 antagonist, chlorpromazine, as well as methylprednisolone. Since corticosteroids, unclear exactly how they work, they reduce pro-inflammatory cytokines, which are implicated in the nausea pathway. And there's also the thought process that they act centrally in the solitary tract in the CNS to actually directly suppress nausea. So in addition to these like general supportive care measures, antiemetics, repleting your lights, consider your fluids with dextrose. If there's a concern for Wernicke's, it's mostly been disproven, but theoretically to avert the risk of precipitating Wernicke's, try to replete your thiamine before your dextrose. And don't forget the small things, or in this case, what really may be the big things. If your patient is this severely ill and refractory to treatment, admit them. Get an RD consult, right? Have talked with them about nutritional strategies, about slow, more frequent feedings. And if they're really that refractory, they just got to be admitted for enteral feeding or have a PICC line placed for TPN. Um, so before we kind of bridge into our toxic and metabolic mimics, I do find it prudent that we talk about or have a somewhat remind ourselves of how um, drug metabolism in pregnancy is different. So before we even go there, if you look at the bottom right of the screen, we'll remind ourselves of the organ system level differences that can happen in pregnancy. There's a lot of stuff going on throughout the body, and that has ramifications. And the ones we'll focus on are the drug metabolism ones. But remember, there's multi-organ system changes that are happening in real time throughout the course of pregnancy. Specifically with regard to drug absorption and metabolism, pregnant patients have a significantly increased volume of distribution. Their blood flow can increase up to 50%. Their body weights can increase 20 to 30% in pregnancy. And so higher volumes of distribution will afford lower drug serum concentrations and the need for dose adjustments. There's less albumin in protein binding, which leads to more free drug bioavailability, and that can precipitate more toxicity in even like normally therapeutic doses. Hepatic metabolism really depends. Some enzymes are upregulated in pregnancy, some are downregulated. You have to know which enzyme pathway your drug is metabolized, but that obviously has implications for clearance. Your renal clearance is almost always going to be increased due to increased eGFR in pregnancy. This results in shorter terminal biological half-lives and the need for dose adjustments. GI motility is decreased while gastric pH is increased. So for your pH-dependent drug absorptions, this can cause altered absorption and kind of slower absorption over a longer period of time. And then with all the hormonal changes in increased estrogen, progesterone, and HCG, those also kind of directly affect metabolic pathways. We can't forget about the fetal considerations as well. Developing liver and kidneys are much more susceptible to toxic doses of drug accumulation and the teratogenic effects that can be seen there as well. All right. So for our toxic mimics, I broadly broke them up into four different categories, and we'll kind of explore some common examples to be on the lookout for that may look like nausea and vomiting in pregnancy, but it may be something else different or scary going on. So we have our drug-induced vomiting, our direct medication toxicities, our environmental exposures, and then our endocrine and metabolic mimics. For our drug-induced vomiting, the most common by far is going to be iron, whether taken alone, like for as part of like a chronic anemia, iron deficiency anemia, or in combination for prenatal vitamins. It's a direct uh, gastric irritant, and it oftentimes will manifest itself with GI side effects like nausea and vomiting. Caffeine is the second most common one. It also has sympathetic activity. It increases gastric acid secretion and lowers smooth muscle relaxation, both of which can contribute to GERD and worsen nausea and vomiting. Uh, Although rare, one of the scary ones you want to make sure it's not is like a salicylate, acute salicylate poisoning. But be on the lookout for your respiratory alkalosis and metabolic acidosis. That'll clue you in. Opioids, whether used therapeutically or recreationally, are direct chemoreceptor trigger agonists, and they will stimulate vomiting directly in the area of hysterectomy. SSRIs or SNRIs, whether started before or during pregnancy, can also have GI upset. In the severe cases of serotonin syndrome, remember your triad of altered mental status, autonomic hyperactivity, and your neuromuscular abnormalities. And then for cannabis, some cyclical vomiting syndrome, whether cannabis is involved or not, it honestly may be very difficult to differentiate. But that's another one you want to keep pretty high in your differential if appropriate. All right, so those are our drug-induced. Next, we have our toxic side effects of medications. It's pretty rare, but it's a cool one. So digoxin, as we know, has a very narrow therapeutic index, and although it's rarely used, it is safe to use in pregnancy. And for the reasons we discussed before about the altered pharmacokinetics and dynamics in pregnancy, that therapeutic window, even if they've been well maintained on a normal dose, may very quickly change in the setting of advancing gestation. So just keep an eye or do a good med rec for that one. Lithium is actually safe to use in pregnancy. There was a recent like panel discussion at the Poison Control Center at their last conference, and it's still considered a first-line therapy for bipolar 1 in pregnancy, even without trialing other antipsychotics. If you have a bipolar 1 patient who's been well maintained on lithium, and responded favorably, it is very appropriate to continue them and not try to trial other antipsychotics throughout pregnancy, understanding the small but not insignificant risk of like cardiac defects. But like we said before, especially in the setting of severe volume depletion, your serum lithium concentrations can be like quite elevated and mimic GI upset. For patients being treated for TB, isoniazid can cause pyridoxine deficiency and precipitate GI upset. And in severe cases, you get your seizures, which are refractory to benzos. And for your patients with seizure or primary mood disorder who may not know they are pregnant, making sure they're not taking valproic acid, right? If they did not yet know they are pregnant, as it also will cause vomiting, lethargy, and transaminitis. Uh, for environmental considerations, lead exposure, very much going to be GI heavy in its manifestation, so just screen your patients appropriately. Carbon monoxide will cause the nonspecific headache, vomiting with a normal SpO2 and can be difficult, but usually there's an exposure. Organophosphates, I won't go into in detail. We had a good lecture on it recently, but remember your dumbbells mnemonic as part of your cholinergic toxidrome. And then for mercury, you'll typically see focal neurodeficits like ataxia or tremor, but GI will be your first side effect as well. And last, probably the most high yield are going to be your endocrinologic and metabolic mimics of nausea and vomiting in pregnancy. So thyrotoxicosis, because of the autonomic hyperadrenergic surge, it's going to manifest with altered mental status and GI upset. DKA, you're typically going to see more profound ketosis. It'll typically shift more towards like a beta hydroxybutyrate heavy ketosis as opposed to your acetone or acetaldehyde. And then for patients with a known primary adrenal issue or those on chronic steroids use for any number of rheumatologic conditions, abrupt cessation of steroids can induce an Addisonian crisis, which can mimic nausea and vomiting in pregnancy pretty similarly. So screen your patients appropriately for that. Okay, so those are our four mimics. Let's see how you guys can do. So we're gonna conclusions. Screen all your patients for HG. It's easy, it's cheap, it's the right thing to do. Recognize, appropriately stabilize, and work up your patients in the ED. Escalate your care appropriately. You can reference the ACOG bulletin from 2018. And then just always keep a broad differential. It usually will be just nausea and vomiting in pregnancy, but kind of evaluate where they are in that spectrum and rule out your scary toxic, metabolic, endocrinologic mimics. Two quick cases if we have time. So we'll go through them and you'll tell me, is this an MVP spectrum disease or is it a scarier alternative? So I'll just read it. But 29-year-old female, G1, 10 weeks gestational age, no medical problems, 3 days of nausea and vomiting, not tolerating orally. They're dizzy and presyncopal. They have no daily meds, no travel outside the country. Here are their vitals. Their exams remarkable for lethargy. They're very dehydrated, but they have a soft belly. And then we have their labs at the bottom. So who wants to take a stab at, I guess first, is their story convincing? Do their um, vital signs and exam kind of support our diagnosis of nausea, vomiting, and pregnancy? And what specifically about the blood work kind of supports it as well? If someone wants to speak up, I can't see your
I think the story is concerning and the labs are consistent with dehydration and poor PO intake. Uh, Given the gestational age and not being on any meds, I would call this patient like on the spectrum of like hyperemesis gravidarum.
Absolutely. I agree. The story's pretty convincing. The vital signs support dehydration, as does your exam. And then on our VBG, you could see it's a alkalosis, right? Elevated pH. Is it a metabolic alkalosis or not?
Yeah, metabolic.
Yeah, so it's a metabolic acid alkalosis, sorry, and in this case, it's a appropriately compensated with a respiratory acidosis, but a primary metabolic acidosis in the setting of severe vomiting with hypokalemia. So it's a pretty good uh, case to support a nausea and vomiting in pregnancy syndrome. All right, what about, sorry, case two, 25 G4 at 22 weeks, has a history of hypertension and insulin-dependent diabetes, 2 hours of nausea, vomiting with belly pain, dysuria, ran out of insulin. There are their vitals. They're also lethargic. They're also dry, but they have a tender belly on exam. And here are their labs. Someone else?
So this story is a little bit more concerning for something outside of Hyperemesis gravidarum, most likely DK as well as UTI. Just given the vital, she's febrile, she's tachycardic. She also has suprapubic tenderness, and then labs are consistent with acidosis as well as hyperkalemia. She has a elevated beta hydroxy, and she has a white count and
Excellent.
a
You
UTI.
hit it right on the nose, right? She has comorbidities that, are independent of risk factors for nausea, vomiting, and pregnancy. The vital signs are a little more concerning. And there's this high NIH metabolic acidosis with evidence of ketonemia and a positive infectious source. And just gestation wise, too. It's a more advanced gestation. There's more like compression from a large gravid uterus, and it does predispose patients to UTI and other ascending GU infections. Excellent. These are my sources, and thank you, everyone.